Welcome everyone to the first part of episode 3 of our Smith & Nephew sponsored special edition podcast series. I'm Andrew Duckworth and a warm welcome back to you all from your team here at the Bone and Joint Journal. As you may know, this special edition series is focusing on hip replacement surgery, including what the current issues are, what the emerging technologies may be that help with these issues, and what the future may hold for this area. In this episode, we will explore the evolving landscape of total hip arthroplasty with a particular focus on the innovations shaping the future of hip replacement. We will cover the growing importance of intraoperative efficiency, the latest advancements in stem design and personalized surgery, and we will examine how these developments are changing the landscape for patients and surgeons. So for today's podcast, I have the pleasure of being joined by 3 guest surgeons and a colleague here from the BJJ. Firstly, I'd like to welcome back Dr. George Haidukewych, who's an orthopedic surgeon based at Orlando Health. George, great to have you with us.
Good morning.
Secondly, I'd like to introduce Dr. Molly Hartzler, who's an orthopedic surgeon based at Wake Forest University. Molly, great to have you with us.
Thanks for having me.
Thirdly, I have the pleasure of welcoming Dr. Thorsten Seyler, who is an orthopedic surgeon based out of Durham, North Carolina. Thanks very much for joining us, Thorsten.
Morning, excited to be here.
And finally, I'd like to welcome back my editorial board colleague here at the Journal, Dr. Jonathan Vigdorchik, who is based at HSS in New York. Jonathan, great to have you back with us.
Yeah, thanks for having us and welcome to our speakers.
So Molly, I thought we'd kick off with yourself. I was hoping we'd talk about the use of day surgery centers and maybe look at for our listeners, your own experience of day case hip replacement surgery.
Yeah, so I actually do same-day surgery out of a small hospital that is mostly orthopedic surgeries. So it's not a true ambulatory surgery center, but we do run very similar to it. And that efficiency is paramount. We spend a lot of time preoperatively optimizing our patients. We use the ERS type protocols, significant preoperative education, and then we have some constraints in terms of, our shelf space, the efficiency of turnovers and things like that. We've sort of slowly increased our same day discharge numbers, both because of data showing that it's safe to do so in certain patients. And then also, I think one of the things that COVID did was sort of force people who weren't doing same day discharges to kind of move in that direction.
Yeah, that's very interesting. And actually, like you say, I think COVID has sort of forced people in that direction. Thorsten, do you have any thoughts or comments on your experiences with that?
Yeah, so I operate in 2 settings. I do same-day discharge in a hospital setting and at a freestanding outpatient ambulatory surgery center. Molly is right. We kind of got forced into, at least at the hospital setting, go into the same-day discharge during COVID. And I think this is where we learned a great deal on outpatient surgery. And it helped us become certainly more efficient at the ambulatory surgery center. And over the past 2 years, I would say we have really pushed the limits who we take to outpatient surgery. Yeah. I think most surgeons, when they start off, are cautious who they select as same day. I would say at this point, almost 80% of the patients that we see are candidates for same day discharge, if they're comfortable. Okay. And the key to this is really truly preoperative education.
Yeah, absolutely. Jonathan, would you agree with that?
Yeah, I mean, over time, we've seen an evolution from, a week length of stay to 3 days to 2 days. And if you can get to 1 day length of stay, all you're doing is compressing all that preoperative and perioperative education, into the couple weeks leading up to the surgery period instead of trying to cram it all in while they're in the hospital. So our patients get physical therapy prior to surgery, so they learn how to use the walker and things. They get the home education or to get their home set up prior to surgery, not when they're in the hospital just sitting around doing nothing. So as soon as you can get to 2 days, you can definitely get to 1 day. And if you're at 1 day, there's almost no difference in a same day discharge other than making sure that the patient is medically safe for that kind of setting.
Yeah, absolutely. And George, do you have a similar setup where you're based?
Yeah, we have a relatively unique setup where we have an inpatient hospital and also a freestanding surgery center that are right next to each other. So in our freestanding surgery center, those are the patients that are going to go home for sure, 100% chance they're going home. And in the hospital, I'll still do outpatient surgery, similar to Molly, and discharge them that same day if they meet criteria. Sometimes you have that frail 72-year-old that you're not sure how she's going to do with the anesthesia, or the older gentleman, maybe with some urinary retention. Sometimes we'll keep them overnight, but Probably 85% of our patients are going home the same day, some directly from a surgical center, others from an inpatient hospital where we choose to do them outpatient. Does that make sense?
So, Molly, sort of moving on from that, what about how optimizing efficiency in the setting, for example, the concept of tray efficiency and how this can potentially help workflow? What benefits are we seeing there?
Yeah, so we've had a big push towards train efficiency. We have had some overwhelm in our SPD department, our sterile processing. And so both on the hip and the knee side, we've tried to push towards, single trays, the, bare bones instrumentation that each of us needs. And then on the knee side, peel packing our trials and things like that so that we're only opening exactly what we need. It's helped both with sterile processing and also with turnovers because there are fewer trays to open. And then, if something happens to be contaminated, we can pass it off and, get something identical in very quickly.
Yeah, absolutely. That makes a lot of sense. And sort of related to that, Thorsten, if I can come to you, the idea about the role of powered impactors. I know this is a thing now, what benefits are we seeing with regards, things like ergonomics, efficiency, and maybe implant placement, I suppose?
Yeah, Andrew, this is we can go on and talk about this for an hour probably. This is an interesting point because I think a lot of this is driven by vendors. And I recently published on this topic too, and the data is truly limited. I don't in efficiency, we know using a powered impactor, you're going to be a little bit faster, you're a little bit more consistent, clinically translate to better fill, but in reality is most of these studies are done with newer stem designs, so they have a very different geometry to older stem designs. So I'm not 100% buying this at this point. And the long-term data in terms of survival, even periprosthetic fractures, is not there. There isn't the significance in there if you look in the papers. And if you would survey everybody that's on the call, and I know George doesn't use it, I have them, but I don't use it. There is something to it to impact a stem manually because that tactile feedback is something that I want to see as a surgeon. And I think in terms of efficiency, yeah, you gain a little bit of time, but I think clinically I haven't seen the value that is being sold to us.
That's really interesting. And anybody else have a sort of thought or feel or a different opinion on that?
So I use Power Impactor for every case, and I have for the entire 6 years of my career so far. For me, it's less about efficiency and reproducibility and more about body preservation. Even coming out of my fellowship, where we did upwards of 900 cases in the year, I was getting tendonitis and, shoulder pain and things like that. And so, to me, to have a long career doing this big joint surgery, having a powered impactor is very helpful. I do think that with time, you develop what the tactile feedback should feel like. It does, the way the impactor feels does change as you get to size and things like that. But it takes time to trust it and to get to know it. So I think, willingness to give it a little bit of time is part of it. But again, there's no real data to kind of push people. So preference is important.
Yeah, but Molly, you bring up a really important point. I mean, I'm going to go here because I want to. Over the many years that we've been training, I've been privileged to be at institutions that train a lot of females. And over time, they'll say, I don't want to go into joint replacement because it's too physically demanding. I'm not strong enough. I don't think I can do the surgery. And I've always told them, you just have to do it smarter, right? You can absolutely do it. So what you bring up in terms of the ergonomics, the body efficiency, preserving your body, and also opening up the field in our specialty, I think, to people who are maybe less strong, smaller statured, that can do this operation in a more consistent manner, I think is super important with these types of smarter instruments as we go forward, right? What are your thoughts there?
Yeah, I agree. And I think, what I usually tell my fellows is that, I'm tall, but I'm not especially like strong. And I can hit harder than the impactors. So there are times when I have patients with hard bone, I can't get the acetabulum down with the powered impactor. I put a strike plate on there and get after it. So it's important to know that the impactor isn't giving you more force, but it is, it's saving saving you hundreds of mallet strikes, over time. So, or thousands even. So yeah, I think that that's helpful. And then, one of my partners just recently retired, and towards the end of his last year, it was a lot of, my hands hurt, my arms hurt, my shoulders hurt. And that's 25 years of doing this. So, I think, it could potentially make our field a little bit more attractive to people who traditionally wouldn't be drawn to it because of potential physical limitations. But I do think that being attentive to, body ergonomics and, injury at
Longevity.
work is important.
Absolutely.
I think that's very true, Molly, isn't it? And actually, we've got to look after ourselves as well as our patients as we go through this. I think it's really important. And maybe moving on from that, Thorsten, you mentioned it briefly there about STEM design, and the, what are the current trends we are seeing in terms of this and usage in the US, and why do you think we're seeing it?
Yeah. So again, if you look at this, if you look at our registry, the report from last year, there's one particular STEM design that now has 30% of all STEMs that go in market share. We're going to see that most of the vendors in the past 12 months have released a similar triple taper stem design to catch up with that stem. So you definitely see a trend that goes away from a single wedge or dual wedge to triple tapered stem. And while one company right now owns 30%, I think you're going to see in the next couple years in our registry, probably upwards of 50-60% of the stems that go in are going to go in a triple tapered design. And on top of that, I think you're going to see a shift back to using stems with a collar, because I think that the data around the world using a collar is very compelling. And I think this is something that we definitely realize in the US. But I think that's where the trend is going to go. I think triple taper stems, and then probably the combination with impactors, because that's the marketing that we see coming from the vendors at this point.
That's really interesting, Thorsten. And George, maybe come to yourself, because are you seeing this as well, this sort of trend, and in terms of things like periprosthetic fracture rates, is that also having an impact, particularly with these collar stems?
Yeah, there's some pretty good data that the tri-taper collared philosophy has a much lower fracture rate than, say, the tapered wedge, or even in almost equivalent to some cemented stems, which is pretty impressive. So I think that design has taken over. I don't think we're ever going back to the wedge, the medial lateral fit and fill type stems or any of that. And I think the overwhelming majority, I agree with Thorsten, that there's really no downside to using a collar other than perhaps extraction of a well-fixed infected stem, which adds a layer of complexity, but that should be rare. And in our practice, and then pretty much all of Florida, the tri-taper collared is taken over. And even interestingly, in more elderly patients, there's pretty compelling data that they could perform as well as cemented stems. So now we're pushing the indications for uncemented fixation to some pretty capacious canals and getting away with it. We're not seeing a rash of periprosthetic fractures. I don't know about you guys, if you want to chime in on that.
No, we've got the same experience. I mean, we've had 4 surgeons transitioned early, and we looked at our periprosthetic fracture rates, where we went from 1% or 1.2% down to 0.1%. So that's kind of all comers, and a lot of us have cemented, 2 or 3 in the last several years. I went over to the London HIP meeting, and Ferris asked me to present on triple taper collared stems and our data. And I thought, I'm walking into the UK talking about non-cemented stems. This is not going to go well. And I sat through a session where they're presenting late periprosthetic fractures with all their cemented stems and the upticks that they're seeing over time. And yeah, there's some trouble with the registry data, and then I show up with a 0.1% non-cemented stem fracture rate, and they're like, wow, maybe we should all start considering changing in the UK as well. So this is going to be hopefully a worldwide phenomenon to help our patients, right?
Yeah, that's very interesting, Jonathan, because certainly as a trauma surgeon, it's something that we're seeing a lot of, and it feels like it's on the rise. It's certainly not a regular fixture in our trauma meetings. Thorsten and Molly, do you have anything to add to that at all?
Yeah, so I think when Jonathan talks about the fracture rate, this is similar to what we see I think another really nice feature of it is when I see some of my partners that have been lifelong users of different stems and they switch to triple taper stem, the feedback is always is, man, this is so easy to put in. And I think this is something that we hear in George when we go to meeting, we hear this all the time. It's like, oh wow, that this is, it's almost like natural because it really hugs that medial calca, it slides down and when it fits and it follows the anatomy, there's something about this stem design that makes it, I think, beneficial for the surgeon as well as for the patient. And I think that's why I think a powered impactor with this, because all it does, the canal is providing the template and the power impactor just put it down until it sits. So I think that combination may be a winning combination.
Yeah.
So I think that's what I have to add to this.
It's really interesting. How about yourself, Molly?
Yeah, I agree with what's been said. And I think it's also important to note that there are potential downsides to cementing, especially if it's not done well. One of my least favorite revisions is a loose cemented stem where I'm, trying to fish out cement from a soft canal that's easy to perforate. And I would love to see less of that.
For sure. So, Molly, if I maybe stick with yourself and we'll move on from sort of stem design and then and look on a bit about the approaches being used for both primary and hip revision hip surgery. What are your thoughts on the role and potential benefits of the direct anterior approach for these type of surgeries?
Well, so the direct anterior approach, we know it's getting more popular every year at AUKUS. In the polling data, it becomes a more widely utilized approach. And I think, part of that is that there is some data showing there are some benefits to it. It's something that patients are aware of and are asking for more and more. And I also think that since the time that I was applying to and going into fellowship, it's become more commonly taught. So I don't think that it's going anywhere. I think it's here to stay. And I also think that as more and more surgeons use it as their primary workhorse approach and get more comfortable with it, that we're going to see more people doing revisions from the front as well. Data on whether or not that's beneficial is not really there. It's been shown essentially to be not inferior to posterior approach revisions, although the indications for anterior revision tend to be a little bit more narrow for most surgeons. Like if a well-fixed stem needs to come out, very few surgeons are going to do that from the front currently. But for me, I think it's my most comfortable approach. And so I'm going to use it almost everywhere that I can. And it has the added benefit of using fluoro, having the table be your assistant instead of another human being. And so I do think that there are some benefits to it.
Interesting, Molly. Thorsten, yourself, any experience with it and your thoughts on it?
Yeah, so Andrew, as you may know, I trained at the institution that Molly is right now. So I did a lot of anterior approaches coming out of training, and then kind of my practice evolved from a DA to anterior-based muscle sparing to returning to posterior, and now doing a STAR approach, which is just a minimally invasive posterior hip approach. So I think the debate about approach is you got to acknowledge that about 50 to 60% in the US of the hip surgeons are doing a hip through a DA approach. There are advantages to it. But I don't think it is vastly superior to a posterior hip approach. I think a well-done posterior hip approach, you can have equal outcomes. The benefits of a DA approach is certainly in the short term, but not in the long term. And I haven't seen any convincing data to make me believe that it is truly superior.
Absolutely. And George, anything you'd add to that?
Yeah, I think I agree with all the comments. There's no data that shows it's better in any long-term parameter, nor do I think there will be, because if you put in a hip correctly, it probably doesn't matter what approach. You got to look at, the early benefits and also the risk profile, right? So DA has clear benefits in the literature about early discharge, earlier return to getting rid of gait aids, and that's particularly useful if you're sending patients home or keeping them very short stay. And then the other thing is the market forces are massive. The standing joke in Florida is if you're not a DA surgeon, then you're a knee surgeon. You're just everybody does DA. It is literally every surgeon I know in the city. It has become by far the dominant approach because patients want it. And I've done all the approaches, and in my hands, it's the easiest approach to send them home from. Sure, you could do that with a mini posterior, but I think just me being able to inject the field and give them some pain relief with some ropivacaine and how they do, they clinically, when they come back to the office, they look phenomenal. A lot of them forget their gait aids and they're moving really well. And that's particularly impactful if, over the last 25 years, I've done all the approaches.
Yeah.
So I think there's a huge advantage in the marketing. You give the people what they want, and the earlier return of function is clear. But there's no long-term difference. And then your risk profile, you're balancing femoral fracture or complication versus dislocation. Yes, they're rare, but those are big deals. Both of those are big deals.
Absolutely, George. And Jonathan, just to finish up on this topic, what are your sort of thoughts on it? And, we've touched on it a bit, but there probably won't ever be any real literature that says one is superior to the other, because correct me if I'm wrong, from what you're saying, I think it's what you feel most comfortable doing, isn't it, really, and what you're good at. And then if you do it well, you're not going to find really a difference, are you, probably?
Yeah, I mean, I think the most important thing George said was that choose your approach and do it well, right? If you do it well, you're going to have good outcomes. And maybe there's certain scenarios where you need to do something differently because of a risk profile. So I think that's really important. But if I haven't done DA in 10 years, there is definitely a learning curve to these approaches, right? The learning curve can be 50, 100, 150 cases, where there's true, each blip on the learning curve is a human being. So you have to be mindful of that as you're going through it. And that's why there's now, Anterior Hip Foundation, different companies all have training programs to help surgeons adopt and do these approaches more safely. And I think combining with powered stems that decrease fracture rates may help. Powered impactors may help in terms of preparing the bony envelopes, technology to help in terms of putting the parts in the right spots. All these helps will evolve and make this approach conversation kind of moot, because, just do it correctly.
Yeah.
And more interestingly, George, you do a lot of trauma, and you, Andrew, as well. An extended anterior approach for big revisions, right? That's just an old iliofemoral approach. And from my understanding, that was always very plagued with a lot of complications. But so I don't know I think smaller revisions through anterior cups, some stems, but doing huge GTOs, big wax on the thigh, I don't know if that's useful or not.
Yeah, I agree with you, Jonathan. I think the old EIF approach we used for old acetabular fractures was very destructive, with very high rate of limp and HO.
Right.
So I agree with Molly. I think for mostly acetabular revisions, DA is going to become just another way to do it. But anything extensive on the femoral side, I have yet to see a logical femoral osteotomy from the extended DA approach. It makes biologic sense to my brain compared to a standard sagittal Poprosky from the back, where I'm not damaging any muscle. Everything else looks like dead planks of bone to me, so I'm a little worried about where the chips are going to fall on that whole philosophy.
Yeah, that makes total sense. I agree, George. So guys, maybe sort of drawing a bit of this all together, sort of maybe looking at all the things we've looked at, and I'll probably ask you each in turn this question. Your overall thoughts on what you think the potential benefits may be of some of the things we discussed here today, if you draw these all together, in terms really, first of all, in the cost savings to the healthcare systems, which is a big important driver now, and also improving outcomes. I don't know, Molly, do you want to go first, or... Thorsten, maybe I'll start with yourself.
Yeah. So to summarize with this, I think we're going to start with this. We're going to get paid more if we do the joint replacement in an inpatient setting than an outpatient setting. So we really have more constraints doing joints in an ambulatory surgery center. So cost matters. There's two ways to bring costs down. A, you increase your productivity, so that means efficiency. B, cost savings through implant savings, through savings in cost of goods that we use, and that includes dressings and other materials. So there's two ways to balance this. So technology comes at a price, right? Yeah. Luckily, the impactors that we see, the companies give us for free, which is really nice. So you don't have any added cost there, but you have a benefit of efficiency because they're time saving. But then you look at the trend that we're seeing in triple taper stems, they are still, because it's a newer stem design, they come at an upcharge to more traditional or more proven stems. So you lose some of the efficiency and cost savings that you have potentially with an impactor right there. And then approaches, George is right. A DA approach is the prime approach for outpatient surgery. The patients have no issues going home, but are you doing this off table? Are you doing this on a Hannah table? You have the cost of the Hannah tables. Most of us run 2 rooms, so you need 2 tables. DA approaches require fluoral. Those are cost factors. I think there's so many things that we need to weigh in, and it has to do with the settings that you work in. I think the key at this time is really one tray efficiency. You got to be efficient in the operating room, delivering a good product, and then the rest is negotiating with vendors and insurance companies to make this a viable enterprise.
That's a really nice overview, Thorsten. Is that anything you'd add to that, George?
Yeah, I think the other thing when we look at costs, we always focus on little things on, how we could save on a surgical sponge or use less, gloves and all, but big picture, if you could decrease complications, improve outcomes, right? So less patients get readmitted, less patients have a periprosthetic fracture, which is an operative intervention. Now you're putting in a several $1,000 long stem, fluted cables, the whole thing, so if you could even decrease your rate of periprosthetic fracture, dislocation, or infection by a little bit, I think the impact on overall cost of care will be massive compared to the other interventions. But I agree with Thorsten and the one case, one tray philosophy. I mean, you need to do more cases per hour in your facility because a lot of the costs are fixed. The C-arm is plugged in a hallway just sitting there, so it doesn't really add too much. But if you can do 7 cases in that room instead of 6 over the course of a year with all the surgeons in your group, because you don't have to open as many trays or an autoclave too many things, or SPD isn't just buried because you have all these unused trays. If you could increase efficiency and decrease complications, I think you're winning on both ends of the spectrum.
Absolutely, George. That makes a lot of sense. And Molly, would you agree that concept that George is talking about in terms of all these things, reducing that complication rate, which really is such a big driver of cost as well, isn't it?
I absolutely agree. And I think that, the things that we've talked about today, including approaches, stem designs, impactors, things like that, they're all designed to have better outcomes for these patients. We're trying to figure out ways to do it better, to do it faster. The only thing that's frustrating is that there's a lot of work that goes into these optimizations. And then on the back end, it's like, oh, well, it looks easy. Maybe we shouldn't be paying these people as much. That's a whole other topic. But, the innovation and the preoperative work, which is substantial, and it's, we know it's better to get these patients out of the hospital earlier, but that doesn't mean that we're doing less work. We're just doing it on the front end. So, I hope people can keep that in mind.
Absolutely. Maybe just to finish up, I'll come to George first, and I'm going to come to you, Jonathan, if that's okay, just to wrap this all up and give us an overview. But George, maybe going full circle and bring this all together, taking it back to for our listeners, some of the things that we discussed in episode 1 or the series, about personalized treatment plans tailored to individual patients and their anatomy and the benefits of these, and how this applies to patient selection, site of care selection we've talked about today, other factors. This is how all this with technology can really drive things forward, don't you think?
Yeah, so a little bit of a multi-layered question. I'll try to simplify it for myself in my answer, but I think the patient-specific planning pre-op, I think the reason that improves a lot of things along the course is, number one, you can trial before you do the operation. You basically do it in your brain on a screen. You know that you're going to need a size 5 with a 56 cup, and when you're in the OR, it makes it much more efficient. I think the importance of the overall episode of care is occasionally you'll see somebody has very unusual anatomy. Maybe they'll need a few different stems on backup, or there's an offset issue, or there's some problems that may require a little bit more equipment for that case. Now, if you know that, and they already open those trays for you, you can be way more efficient than say, oh my God, this stem doesn't fit. We need to get a whole set of ML taper, or this stem's too big, or it's just too small, or I need an 80 millimeter cup because this patient's huge. So preoperatively planning this can make you more efficient in the OR. And then the reps can bring less things. They don't have to open In some cases, reamers that go up to 76 for giant patients, or for example, the 46 cup because the patient's tiny and you didn't anticipate that. So I think the whole pre-op planning is a lot more sophisticated now. And then with modern navigation, small footprint navigation, you can hit your targets and be extremely efficient in the OR. So it's helped my practice a lot, the pre-op planning and individualization. And then if you think about it, you're spending less time in the OR trialing because you've already simulated that. So you know that if you hit your target, you're going to be clear of impingement. And you know your offset. You don't have to guess, put in a standard offset and go high offset. So the whole process of implantation, you're just executing in the OR. You're not checking everything 5, 6, 7 times because you already did it. Perhaps maybe one trial and you go.
Yeah, that's a really nice overview there, George. And Jonathan, maybe I finish up with yourself. That previous question I asked, but also the question that we sort of mentioned a few times on these is that moving forward, in sort of rationed healthcare systems, particularly like in the NHS, proving that all these interventions actually have cost-effective A and B actually give benefits is going to be difficult, isn't it? Because we're trying to improve a very good operation at baseline.
Well, it comes down to a couple things, right? Then we hit on a lot of this. The payers are looking at 90-day complication rates, when in reality we should be looking at 2, 3, 5 years, right? If we look at all the revision surgeries that we do for hip replacement, and we published on this, almost 50% of them were avoidable had you just done the first one correctly. So cost savings wise, we looked at the economics of this. We're looking at hundreds and hundreds of millions of dollars of savings if you prevent these complications, readmissions, right? Periprosthetic fracture, that's $40,000-$50,000 in a hospital stay in implants. Infection needs to be solved because that's $50,000 to $100,000 spent after you spent, 15 or 20,000 on their primary surgery only. So in a rationed healthcare system, the prevention of complications through preoperative imaging, understanding patient-specific risk factors and doing something differently, doing the surgery better is where we're going to see the tremendous amount of cost savings over the long run for these big health systems. And from the surgery standpoint, if you do all that and you become more efficient, do more cases per day, your hospital will also be profitable and not be fighting against revenue margins.
That's a really, really good point, Jonathan. I think a really nice way to sum up everything that we've discussed here today. Well, Tim, I think that's all we have time for. So thank you all for taking the time to join us. It was a really great discussion and some great insights there for our listeners. It was great to have you all with us. And to our listeners, we hope you've enjoyed our special edition podcast. Feel free to be in touch with us about anything we've discussed here today. And thanks again for joining us. Take care, everyone.